Thank you, Chairman Curtis, for letting me come and speak with you today. You all know me well because I talk to you on a regular basis, but I wanted to first introduce you to a couple of our members. So Richard Salmony is a PA in Durham. Dr. Mary Shell Savino is a primary care doctor in Hendersonville. Dr. Kenneth McMahon is an OBGYN in Dunn. And Dr. Kimmy Vong is a medical student, or just finished up graduating her medical student, and is now in residency. These are the people that I get to represent to you on a regular basis, and too often you don't get to meet them, so it's nice to show you faces every once in a while. This is the 2016 representation of where the licensees are for the North Carolina Medical Board. Of all the physician and physician assistant licensees, these are our members. And the point that they make in their 2016 annual report is that there's a maldistribution, just as Dr. Kaufman just pointed out to you, and others are going to point out to you this afternoon. They are distributed along the I-85, I-40 corridor. What this doesn't take into account is the number of folks that are working in those urban areas and doing satellite work, doing outreach work in rural communities. And I'll show you a statistic a little bit later that I think helps to clarify that. One other thing that I would point out to this is that in the last 2 years of the annual licensee reports, physicians have grown by more than 2,000 in the state over each year in the last 2 years. So I know that we would like to grow more at home. I think that's a good thing that we grow more at home, but we're an attractive state for people to move to also. So we need to make sure that we're looking at both ends of that perspective. These are the questions that the committee asked us to look at today. I think we could do a presentation to you on each one of these things. So we're going to get through as much as we can, but hope that we get to come back again later. It was really fortuitous that right after we got asked to speak, the Wall Street Journal released a study on December 29th comparing urban communities and rural communities across our nation. And it was very interesting to me because this is the same kind of thing that we've been seeing in North Carolina. We've been seeing the urban communities grow dramatically, and we've been seeing the rural communities flatline. And this isn't unheard of because there are folks like me that grew up in rural communities in the state. I grew up in Tarboro. This is our town common. And I left, and I didn't go back. I've chosen to live in an urban community, and I think that is happening all over the place, and there are lots and lots of different factors. And if we're going to address healthcare access, we're going to have to address lots of different factors. There's not one silver bullet that's going to get any kind of medical provider to move to a rural community. The fact that the population is aging because the young people are moving away is having a big effect on health outcomes. The fact that jobs are harder to find, that the workforce is dwindling, that the number of disabled workers is growing dramatically, the fact that it's harder to get small business loans, the fact that diabetes and other chronic health conditions are increasing. These are all pieces that were introduced in the 20 slides by the Wall Street Journal. I would beg you to go and look at this because it's really comprehensive and helps you look at this thing from a bigger perspective. These are the multifaceted approaches that I think we're going to have to come at in order to answer this problem. But I do want to wind us back to what is it that we've been doing here in North Carolina. And I know this is just a picture of a bunch of people in a convention hall room, but this is meaningful to us because this is 6 years of work, almost 10 years of work right here to get to where we have now a North Carolina Population Health Collaborative. This is a partnership between the medical society, the health systems, the AHECs, all different kinds of medical providers, community groups, lots of people that come together 4 times a year and talk about the health of our communities. This started off as providers coming together as accountable care organizations and comparing best practices with one another, sharing those best practices and taking them back home. And it's grown because we realized that we couldn't do it all in the doctor's office. It had to be taken care of in other places other than just the doctor's offices. So our solutions are not ones that are things that we can always do here. They're not always ones that can be done by the doctor. They're back in the community, and they're different depending on what the different community is. The things that work in the northeastern part of our state are not necessarily going to work out in Silva. The things that work in Boone are not necessarily going to work in the Sandhills. So we need to make sure that whatever policies you adopt, whatever things you encourage us to do, are things that give flexibility to folks to do things locally with the resources that they have locally, because those resources are not all the same, even in the urban areas, but most especially in the rural communities. The other thing that we did in focusing locally, 28 years ago we started a community practitioner program. And like the state, like you invest in loan repayment programs, we too invest in loan repayment programs. This is the participants in our current year. You can see exactly which counties they're located in. There are 38 folks. We invest about $36,000 per year in each of these folks, which is an investment of about $2.5 million. And this gets them to, many of them, to stay in the communities. This is not so much the enticement to go there as much as, although it is in some cases, but many times it's the reason that why they stay. It's one of the assistances that we provide to help them stay. And why do we do this? First of all, this is where we've invested that money. So over the last quarter of a century, we put $14.5 million into 284 individual sites. 85 out of the 100 counties have received somebody. And you can see that it's not just doctors, it's physician assistants, it's RNs, it's NPs, it's certified nurse midwives. We did a certified nurse specialist, I know, recently. So we are not restricting our funds to just our members. We know that we've got to reach broad with these dollars, and we need to bring all kinds of people into communities. But why are we doing this? We're doing this because there's a huge return on benefit. For every one of those community practitioners we put in place for $36,000 a year, the AMA Economic Impact Study that was literally released just a couple of hours ago says that we get $83,000 in state taxes and local taxes from that one provider that comes forward. You're going to see in a later presentation that that number is far higher than that. This says that we get nearly 13 jobs related to that single physician in that community. You're going to hear higher than that for our rural communities here. This is an average of all doctors in all communities across the state, so it's slightly skewed. It's not delved down to the rural community. But this makes any investment that we can do with this incentive very worthwhile. Because of the conversation that we were having this week, we wanted to make sure that we reached out to our members to have a conversation with them, because this is something that we have anecdotal conversations constantly with them. So we did a poll, and we had 375 folks reply to us in less than 24 hours, which sounds like a statewide poll to me. And you can see that they self-identify themselves as primary care or specialty. They identify themselves as urban or rural, or the combination. That's that statistic that I was talking to you about a little bit earlier, right? Just because they live in an urban area doesn't always mean that they identify only there, because many have a satellite somewhere else. I know doctors that are in Raleigh that travel deep into down east to do satellites. I know folks that are in Boone that go all the way to Murphy to do satellite work. So that doesn't, just because it's their primary location doesn't always mean that's their only place of doing business. And what did they say? They said that they are, I'm sorry about the category name thing there, but they said that they're living there, all these messed up. So they're living there because they want to live there. So the private practice environment was the second largest piece. That means that they want to work in a small practice. The dark purple or blue said they like the rural environment. Service to the underserved, that altruistic place was there. Orange was other. Black, I can't remember what that one was, I'm sorry. And the green was economic incentive, all right? So I just pointed out to you, and we just talked with Dr. Kaufman about the fact that incentives were very important, but it wasn't the primary factor that our doctors told us was the most important thing. And I'll get you a clean copy of the slide to make sure that that it looks better for you, so you can see exactly what that is. We did come back from the comments. We said there were 3 things that were ubiquitous from the comments. We need incentives, but those incentives aren't just loan repayment. They're good Medicaid rates, because the payer mix in many of these communities is heavily Medicaid, heavily state health plan. So as you cut those rates, you diminish the chance of any practice surviving in those areas. Rural residencies and medical training, as Dr. Kaufman was pointing out, are absolutely vital, not just to the continuity of care, but the possibility of recruiting people to come back. And then the use of telemedicine. We have allowed telemedicine in our state, but we're not encouraging it. We are not making it a priority. We're not making sure that people are using it. So ways of funding that, ways of encouraging extended use of telemedicine to make sure that specialists that can only be in urban areas because they can't afford to be in rural areas patients have access to those specialists at a moment's notice. Other things that they pointed out I thought were really interesting. Patient transportation. All right, this has come up in multiple conversations. Western North Carolina Medical Society is having a huge conversation around this right now, and I thought it was interesting that it also then came up in our poll. And patient transportation is not about the distance between the patient and the doctor's office. It's about their ability to actually get in a car and go, or have somebody take them, or have medical transportation, or have public transportation. And there are lots of different barriers there that we could go into. I think that's something that we need to dig into a little bit more and help understand. Reducing administrative burdens. I hear all the time from our rural doctors. Anytime that we put a new regulation on them, it impacts them more because their business is so much smaller, their margin is so much smaller. It's going to have a much greater impact. So even though we completely agree that we need electronic health records, we need data exchange, we need all these things so we can measure quality, because we're moving from just providing care to actually measuring the quality of output and make sure that we're actually improving health in our community. That's our goal. And so we need all that data to do that, but all that costs money. All that cost expense to the practice that they have to come up with. And where they're, like we said, on very tight margins, that becomes very big. Practice assistance is not necessarily more money as much as it is, although it can be more money, but it's help with managing the practice, setting up a good business. It's not something we typically train our doctors to do when they're working in the major urban centers, how to run a small business on their own. And then the insurance options are vital. Like I said, most of the time it's Medicaid, Medicare, or a state health plan. So having other insurance options that are affordable and sustainable for folks that they can actually get and make sure that they have a way to cover those things so we're not having to do this care for free is vital. I left the orange box to the end for a reason. Appealing community development. That sounds like this really quaint phrase there, but it's really true. I mean, if our doctors are saying that they want to practice there right now because they want to live there, then the only way we get more people to go there is to make them attractive for other people to go to. We've got to make these communities attractive. And so as I end, I bring you back to Tarboro. This is catty corner to the church that I grew up going to on Main Street in Tarboro. This is the old cinema that is now a Veterans Museum, and an old tire automobile dealer that is now the Tarboro Brewing Company. Never did I think on Main Street, North Carolina, we would have a brewing company in Tarboro, but there it is, right? Our underground bar lasted ever so briefly there, but our high-end restaurant now on the square where I grew up eating Hot Pockets during lunch, taking a break from the hardware store, is now selling French wine with one of the best chefs in eastern North Carolina. We've got to make and give opportunity to small businesses and people that want to be in these areas. We've got to help them do things to thrive there. And by them thriving there, we'll attract other people. And when we attract other people, we attract doctors, we attract tax base and property tax, and we build up our schools better, and things get better. But that's it. I mean, it's just not a silver bullet. It's a multifaceted approach, and every little thing is going to add up over time. And with that, I'm happy to take any questions and come back and answer other things later.